So we started with heart failure in earlier class, and we have seen various categorization of heart failure on the basis of Newark Heart Association and on the basis of ACC, how they are graded. We have seen various impacts, various biomarkers, how they are there. Now let us go for the next topic, next part into it, that is for various stages, what kind of treatment is suggested, what are the guidelines they are telling about it. So let us go for one by one. So what is treatment for this, where there is a reduction in the ejection fraction? What we shall be doing into it? So let us go for this. Let us see the algorithm which is given over here and what it states. So this algorithm gives very clearly that whenever there is a heart failure and we have categorized it in a stage C, then what will be our objective, what we will be going for. So we can go for the AC inhibitor or ARBs, and simultaneously we can go for the beta blockers if required, diuretics. Okay, so these are the suggested one number we have given, that is class of recommendation, and that is first class of recommendation it is there, that is number 1. Now initially we have given, then let us see what kind of category wise it is falling if we compare with the this just let me enlarge it. Okay, now what category it is there. So let us go for step 2. It is, if it is falling in the class 2 to 4 and the creatinine clearance is better, that is it is greater than 30, and that is no renal problem is there, then we can add aldosterone antagonist. What is aldosterone antagonist? Spironolactone, we have seen it earlier. Okay, then if it is having this class 2 to class 3 heart failure, the blood pressure is normal or adequate, it is maintained when the treatment is given with AC inhibitor or ARBs. There is no contraindications to ARBs or sacubitril. What is sacubitril? Anybody? What is sacubitril? Can anybody answer? No one? This much time you are taking? Okay, go through it whenever it makes time, whenever it is you can write. But this much time if you are taking, that means you are not studying, you have not revised anything. We have studied everything, heart failure in pharmacology, and if you are not revising it, there is no use of whatsoever I was planning or whatsoever I was thinking, that if we study pharmacology first, if you study anatomy physiology first, it will be helping you. I don't think any benefit in that. You are just attending classes, and there is no revision, no other thing. Really pathetic actually. So okay, let it be. So let us go for whatsoever guideline directed therapy is there, go for that. Check it what it is, discontinue AC inhibitors or ARBs and initiate the ARNI. ARNI we have studied earlier in pharmacology. Go for, if it is black patients, that is having NYHA class 3 to class 4, then simultaneously give hydralazine or nitrates. That will be helping into controlling blood pressure better. If it is NYHA class 2 to class 3, but there is a changes in this left ventricular ejection fraction, which has reduced less than 35%, and the person has survived more than 1 year. If the person has survived more than 1 year, and if they survived more than 40 days after myocardial infarction, then go for the intracoronary or intracardiac devices which are there. Then next in that is, if it is second to fourth class is there, so in that patients what you will be doing is, if it is class 2 to class 4 and again left ventricular ejection fraction is less than 35, there is a changes in the QRS, and the beats are the QRS is greater than 150 milliseconds. So in that cases go for CRT or CRTD. That is, CRT is what? CRT is cardiac chelation therapy. Okay. Then if it is class 2 to class 3, and in that cases give ivabradine. This is again we have studied in pharmacology. So these are depending on various patient conditions how we are selecting drug. Particularly it is class 1 to 4 or stage C is there as per ACC guideline. Now after that check out, or there is a reassessment, we call it as a follow up. So go for follow up. There are two things can possible, either there is a change, there is a benefit. We have seen prognosis can be, there are three prognoses. There is a improvement in prognosis, that means there is a betterment in the patient, or there is a no big change but there is no progression of disease or no remission of the disease. Progression of disease means from class C to class D or stage C to stage D, if it is going, we will call it as a progression into it. Okay. If the person is not treated and if the person goes in next stage, okay, that is progression in maybe 2 months, and if it is taking 6 months or 8 months to go in next stage, that much only the benefit it is occurring. And if it brings back to from C to B, that means it is improvement. So in case there are two things, there is an improvement of the symptoms, or there is a refractoriness, or the treatment has not changed much, either there is a increase in problem or it is in same category, then go for again additional therapy, that is palliative care. Palliative means particularly if the patient is going in the end stage condition or almost on the deathbed, then we call it as a palliative, particularly in cancer and such treatment. That is, you take the care of other problems and see that patient is not suffering with other problems, so that his life is not painful. Then go for transient activities. Then check the left ventricular AD, that is another one, and go for investigational studies that what changes has happened. So this is how uh, the guideline based or guideline derived treatment we are making. Okay, so this is how the treatments are there, and how this treatment are helping, how this treatment are suggested into this. So this is one kind of guideline, this is one way how we are making it. We already categorize them as per the guidelines, and then we'll check it what we can do the best into this. Then for stage C with reduced EF, that is HF-REF, again what is there, renin-angiotensin inhibition with ACE inhibitor or ARB or ERNI. So there are three things we can do. So the recommendation is, class of recommendation is one, that is it is first line, it is the best treatment. So what we are going, it is ACE inhibitor is A, ACE ARB inhibitor are again A, and ERNI inhibitors are there. We can use anything we can do out of this. Inhibition of the renin-angiotensin mechanism. अच्छा, उसका क्या हुआ? अच्छा, दूसरी गाड़ी का, ठीक है. The clinical strategy, that is to inhibition of RAS mechanism either with ACAV or ARBs or ERNI. That is very good one. It has already been recommended, and it is found to reduction in the morbidity and mortality. So it is one of the best treatment. It is most important and most widely suggested treatment. It is there. The new clinical trial data prompted clarification and important updates, because ERNI studies are not sufficient enough. So we have to go for more ERNI studies. So far it is looking more promising, but still we have to go for more ERNI studies. Then the second one, renin-angiotensin inhibition with ACE inhibitor for ERNI-B. So this is again stage C, HF with reduced EF, and what we can have, these are various recommendations, and it has been found that it is beneficial. With ERNI, the patient with chronic symptomatic, this one HF-REF who tolerate ACE inhibitor or ARB replacement by ERNI is recommended for further reduction in the morbidity and mortality, and still additional data is required, it is expected. If we go for the ERNI should not be administered concomitantly with ACE inhibitors or within 36 of the last dose of ACE inhibitor. We have seen it in pharmacology. Okay, so this is dangerous one. Or ERNI should not be administered to patient with the history of angioedema. In these two cases, we should not go for ERNI. That is, otherwise it can be harmful. Then next type of drug which is preferred is that is the second line or 2A class, that is ivabradine. It can be beneficial to reduce the hospitalization for the patient with symptomatic stable chronic HF who are receiving the guideline derived managements, and it is including the beta blocker maximum tolerated dose. It can be given. So this is newer data. This shows that it is beneficial. Then again the class of recommendation is one, that is it is the best, where benefits are much more than the problems. And here the systolic blood pressure and it should be controlled in the patients in accordance with the published clinical practice guideline. Diuretics should also be used for the relief of symptoms due to volume overload, and thus it is better one. It can make better, it can add it. There are class 2As are there, various kinds. So what we can do, we can go for coronary revascularization when there is a coronary artery disease. We can manage the atrial fibrillation with various treatments which are available, where the another kind of changes with the ejection fraction is there. We call it as HFP, that is preservation is reasonable to the improvement symptomatic. and we can use the beta blockers and AC inhibitors and ARBs in the patient with hypertension, which is reasonable, and control blood pressure. We can go for the appropriately selected patients with various conditions, and if there is a elevation of BNP, we have seen BNP is a very important marker, and in that cases we can go for aldosterone receptor antagonist. They can be decreased to decrease hospitalization, they can be added. The use of ARBs might be considered to decrease the hospitalization for patient with HFpEF. So this is another, we have seen two important conditions, HFrEF, that is which is called reduced EF, and HFP is a preserved EF. So we have seen these two conditions. There are no benefits of using nitrates or phosphodiesterase 5 inhibitors, and therefore should not be used. Rather, there are no risk, there are no much benefits, and it is useless treatment. Use of nutritional supplements is not recommended for the patient with this condition. Now, what are the important comorbidities in HF? We have seen that simultaneously patient may be suffering from many diseases. Already we have seen cardiovascular problems like hypertension, then maybe ACS, then arrhythmias. These are some of the comorbidities which are related to diabetes, hyperlipidemia. Some of these we have already seen. Let us see some more, that is anemia. So if it is anemia, then what is to be done? If transferrin saturation is less than 20%, intravenous iron supplement can be given, because if there is anemia, already heart is pumping less, there is a heart failure, ejection fraction is less, and if there is iron deficiency anemia, then in that cases it is better to improve the this oxygen carrying capacity by improving the hemoglobin, and this should help in improving the oxygen carrying capacity. Then in the patients with HF and anemia, erythropoietin stimulating agents should not be used to improve the morbidity or mortality. So this shows erythropoietin should not be used. Hypertension already we have seen, but let us make a fast review of it. Optimal blood pressure should be maintained between 130, 80, this one. Then the patient with reduced ejection fraction should be prescribed with the general guideline management therapies, which are titrated to attain systolic blood pressure less than 30 mm of Hg. Then the patients which are having the volume overload should be prescribed this treatment to attain the systolic blood pressure less than 130 mm of Hg. Then those who are having sleep disorders, then servo ventilation should not be used. This is a mechanical ventilation which is given for the sleep apnea. It should not be given, it can cause harm rather than benefit. Then other one which are beneficial, these are in sleep where there is a excessive daytime sleepiness. Formal sleep assessment is done, and accordingly treatment can be given to this patient which are having cardiovascular diseases and obstructive sleep apnea. So these treatments are given so that there can be improvement in the activity. Then this is related to ARNI, that is angiotensin neprilysin inhibition in acute decompensated heart failure. This kind of studies are performed, and these are published, and from these articles, from these studies, we call them as a experiences, and on that basis we make our guidelines, and then we make the CORs, that is class of recommendation. If the study is good, if many people are there, and many subjects are there, then we find that the study is good, then we can use it, we can take it. So in that cases, this study says, the study name was Pioneer HF study. So this Pioneer HF study says that what are the benefit. So that shows acute decompensated heart failure accounts for this many death we have already seen. So what they have done is they have tried for drug like sacubitril and valsartan treatment that has decreased the death of HP, that is heart failure hospitalization, as compared to enalapril. Patients with ADHF requiring IV therapy was excluded, and these were the study things. And what was concluded from that, that among the hemodynamically stabilized acute heart failure patients with reduced ejection fraction compared with enalapril, this one sacubitril and valsartan administered over 8 weeks, it found a greater reduction in the this N-terminal pro-BNP, that is brain natriuretic peptide, was reduced, and this has indicating, or this is indicating that it is helping, or because this is a biomarker of heart failure. So reduction means there is an improvement in the condition, of prognosis is good. Reduced rehospitalization for the heart failure. It was well tolerated and comparable rates of worsening renal function and hyperkalemia, symptomatic hypotension and angioedema, and thus one can make that it can be better. The results support the in-hospital initiation of sacubitril valsartan in stabilized patients with acute decompensated heart failure and reduced ejection fraction, irrespective of prior ACI inhibitor ARB uses or prior HF diagnosis. Then another therapies which were during hospitalization, there is another article from Journal of American College of Cardiology, that is JACC, heart failure, and it was found that initiation, continuation, switching to withdrawal of heart failure medical therapies during hospital. So what are the impact of this initiation of therapy, continuation of therapy, switching therapy, either drug or intervention, and withdrawal of any treatment, what will be impact of it? So it shows that the hospitalization in patient with heart failure and reduced ejection fracture provides key opportunity, and various trials are there. They have shown that what will be what should be the guided treatment which should be there, particularly in case of the example is low dose beta blocker in hemodynamically stable patient. It was well tolerated and reduced the rehospitalization, improved functional status. Switching from non-evidence based beta blocker, we have seen this all earlier studies, journals, we call it as a evidence based. To evidence based beta blocker has not been studied, but it is clinical, it is well tolerated. And this study shows that continuation of beta blocker during this hospitalization is associated with the lower risk of rehospitalization and post-discharge mortality. Withdrawal or dose reduction in the beta blocker should be considered in patients with hemodynamic intolerance, borderline perfusion, cardiogenic shock, or inotrope requirement. Careful attention should also be paid to the patient with bradycardia due to risk for progression to heart block and tachycardia, and it can be compensatory mechanism for a stroke volume. When the stroke volume is low, then it will be compensatory. There are no randomized data which are assessing hospital initiation or continuation of the AC inhibitors or ARBs, but the observational study suggests that in hospital initiation of AC in ARBs correlate with the lower 30-day rehospitalization and mortality rate, which persists for 12 months as well. So that means it is proven by various studies that AC inhibitor and ARBs, they are reducing the mortality rate and the rehospitalization, because patient is stable then and need not to be hospitalized. Then next is the in-hospital continuation of AC and ARB was associated with lower post-discharge mortality and rehospitalization. Common reasons for their discontinuation are hyperkalemia and renal dysfunction. Some caution should also be used in initiating AC inhibitor ARBs in hypovolemic patient, as this may be associated with the hypotension. Then the heart failure therapies during hospitalization. What are the various therapies during hospitalization? Just now we have seen that ARNI is one of the promising newer treatment, and it has been found that it is beneficial than the AC inhibitors which are there. And clinical benefit in hospital patient, if they are switching from AC inhibitor or ARB to ARNI, these are the beneficial one. In patient also, initiation of ARNI therapy can particularly in E-volumic, where the blood volume is same and they are tolerating ACE-ARB, can be considered and will increase the rate of post-discharge uses. Some similar trials shows that spironolactone also beneficial in patients which are having this impact of potassium sparing diuretic, and it can be causing reduction in that. It reduces arrhythmia and it reduces the greater congestion relief. So these are beneficial effects they are having. Continuation of spironolactone during hospitalization, it has not well studied, but it can be again, people believe that there is a beneficial, it is more safe, well tolerated in most of the patients, and therefore this spironolactone should be increased. Why it is less, again it has to be thought about, and plans should be made for more such results. Patients in the hospital with having reduced ejection fraction should be counseled and educated regarding the need of this guideline determined management of this treatment managements and anticipated side effects. The close follow-up of this discharge will with the lab monitoring, it's mandatory, and therefore treatment, the patient we call a treatment new, means those which have not received any treatment or they are new. New means new. So treatment new means which are totally new to the treatment, which we will call it as a treatment new. Then what hemodynamic monitoring is required in heart failure management? We have to maintain the blood pressure very meticulously. We don't, because if there is increase in the pressure, it will increase the afterload, and therefore there are some systems are there, computerized systems are there, which will be measuring the blood pressure, and it will be storing it, and it will recommending. So these are the example of this is CardioMEMS heart failure system is there, which is a computerized one. Then there is one champion clinical trial that was made. So there was worsening of the heart failure leading to heart failure hospitalization. It contributes to disease progression. So if there was acute event after that, and if with time if the care is not taking, then you can see that there was acute event, then that reduced the myocardial function. Some treatment was started, but it was not taken care of. Then again it will happen, and it will make problem, and gradually it becomes zero. That means patient is died. When it touches to this line, or whenever it is going towards this line, that means the death of the patient, because now heart is not functioning. So with each subsequent heart failure related admission, the patient leaves the hospital with further decrease in the cardiac function. So these are the graphs which are showing on various number of patients. One can see the effect study shows that around 9,000 patients were admitted, while the another one it shows 14,000 subjects were present in that, and they show impact of various admissions. That is, first admission, what was the activity on second admission in hospital, on third admission, and on fourth admission, what were the changes, what were the situations. And it shows that each admission decreased the patient chance of survival, because every time person is going to hospital only when the problem is severe one. So every time all of a sudden it is becoming severe, many times it is either it is not responding to treatment, or the patient is not taking treatment properly. So in that cases, once the patient, if the patient has to hospitalize second time, third time, so every time it means that the patient has got a poor compliance, or poor response to the, or poor prognosis we will call, and then because of that the death is inevitable, or the patient cannot come out from the problem. Then next is what is the congestion state, and say how people are now monitoring it. So what is the congestion state at the time of discharge? So there is a mild congestion or moderate congestion. If it is white color, that means 40% are having moderate congestion, and 60% are having almost no congestion. Okay. Now congestion state, patient discharged without congestion at 60 days follow up. Then what we can find is again this 59% they were there, means from 60 now we are got it reduced to this 59, and which was moderate to severe. Out of that, 20% are now this they are maintaining the decongestion, they are well, and there is a 59 are having decongestion, 24 are having partial congestion, and in 17% there is a relapsed or there is a severe congestion. That means these patients are increasing slowly. So this is how the problem is there, and these treatments are showing that it should be there. Then what is that I told you, cardia MEMS system is there. This some device is put into pulmonary artery, and this pulmonary artery pressure is sensor is implanted via right heart catheterization procedure through femoral one, and then this it will be fitted into like this. If you can see this red circle in this figure, here you can see that this device is fit into it, and then it will be measuring the various parameters, and this data will be used. So it will do this pulmonary artery pressure sensor on the catheter delivery system. Very small, very fine machine it is there, and then it will keep this database which is there. The physician can keep access of it, physician can have continuous information about it. Patient has got this unit just like you have got Wi-Fi. So this will give the message, this will be taken into this Wi-Fi, and it will be stored in the graphical form that doctor can check and can have the idea about it. This shows that if it is there, then in that patient the treatment can be properly monitored, and there is always benefit in these patients when such kind of systems are working. But definitely they are very, very costly system, and they are not easy to do it in country like India. So these are what various. Then one more thing we have not discussed, we call it as a cardioversion, or giving very stronger electrical current shock there. Most probably you might have seen in various film it is shown. It is used in various conditions. It is used in arrhythmias also. We have discussed it during arrhythmias. During heart failure also, this shock is given so that the impulses are taken up by heart, and these impulses, similar to the external electrical current, these are reaching to heart, and this will cause very powerful impulse, and maybe almost the heart which was not beating, if it starts, there are every chances that then heart will continue beating. This is almost last option or last resort the doctors are going for. And another is there are agents like defibrillator which are available. They are also for arrhythmias, which are maintaining the synchronized heart rate, and they allow external current for the heart beating in a proper sequence. So these few treatments, they can help patients in this heart failure condition.